Good afternoon, everyone. At the outset, I would like to thank the organizing committee and allowing me to share this podium. So before I start, I would like to share a few datas so that will show why we should look into the timely and early intervention for these cystic pancreatic neoplasms. So way back around a century back, McWhorter first compiled the cases of pancreatic cyst from the Chicago Surgery Society. About a decade after, C.H. Vance gave his first publication on the NEJM, and following which we have a number of guidelines, and the last one was published by Kyoto in the year 2024. This data is also being impressed by the fact that our publications was less than 100 per year when we go back to 2005, but when it comes back to 2024, it's more than 1,000 per year. Cystic neoplasms or the cystic lesions in the pancreas can be divided into three parts. There's a benign, pre-malignant, and malignant, of which we'll concentrate on the pre-malignant part. Those are the lesions that can give rise to malignancy in the future times. So PIN is a separate entity from the other three, that is IPMN, MCN, and ITPN, because it is rarely being picked up by the radiological investigations. So they can be of high grade or low grade. Initially, it was being divided into three parts: high, intermediate, and low. But nowadays, it is being now classified into low and high, because low and the intermediate grades usually have the same outcome. Cancerization of a duct is an important part of PIN, and that we must look into. And another important part about the PIN is that it often resembles the dilated neoplastic duct of pancreatic ductal adenocarcinoma. IPMN, these are usually the mucin secreting tumors, so that either arise from or connect the pancreatic duct. Although there is no ductal obstructions, there is atrophy of the surrounding parenchyma. So this is important. Again, it's divided into three parts: the main duct, branch duct IPMN, and a mixed variety. The mixed variety usually follows the course of the main duct IPMN. MCN is usually more common in the females, usually occurring in the tail regions. ITPN is intraductal tubulopapillary neoplasm, is usually a recent variety, where the tumors are usually more than 1 centimeter in size, and they have a histochemical histobiology of high-grade dysplasia. Second part to suggest that we should do more investigation in the early part is the progression of the tumor. If we go back into the tumor cells doubling time, it's usually 40 to 60 days in case of pancreatic cells. So for this mass to grow into a 1 centimeter or to a size of 1 billion cells, it usually took many years. Second, we look into the tumor progression times, which is published in 2012 in the gut, which shows that the progression from normal tissue to the cancer is around 11.7 years, and another 5 to 6 years it took to become metastasis. So we have a long period of time where we can diagnose and do intervention so that we can have a better outcome. Coming to the incidence of the cystic neoplasms, so in the west and in the east, it's nearly the same, around 2.2 to 2.6. The incidental pancreatic cyst, which in the CTs are recognized up to 2.6, but in MRI, it can go up to 49.1%. The incidence of IPMN, which is one of the most important part of these cystic neoplasms, is 0.2 only in 30s, but it can goes up to 6.6 in 70s. Next, coming to the 5-year survival. So if a patient is having an invasive carcinoma with intraduct IPMN, then the survival is around 30%. For the mucinous, it is around 60%. And for the PDAC, it is 11% if the disease have an regional disease. So if we amalgamate all these things, so cystic neoplasms to start with is a benign disease. It has got a malignant potential, although it can have a long period of asymptomatic period, but timely intervention can improve the survival. Benign disease, it has an excellent outcome, but the invasive disease have a poor outcome. This is the usual way of classification, where we classify the tumors into epithelial and non-epithelial part, where again the classification is done into neoplastic and a non-neoplastic part. And what is important to us is the epithelial neoplastic component, that is IPMN, mucinous, and the serous part. So there are some important features or interesting features in the clinical features of this cystic neoplasms of pancreas. The tissue of origin is very interesting. So in IPMN, the stem cells usually resides in the epithelial lining of the main pancreatic duct or the branch ducts. So from where the cells arises or the neoplasm arises. In case of MCMN, there are some doubts whether the pancreatic remnants are there or it is the persistence of the primordial germ cells that is persisting at that region during their migrations. In ACN, it usually arises from the centroacinar or intracaroted cells. There are some fancy terms which we can use to describe the gross appearance, like the IPMN usually have a grape-like appearance, the MCN can have an orange-like appearance, and SCN can have an honeycomb-like appearance. The internal structures to describe IPMN is usually cyst by cyst. For MCN, it is cyst in cyst. So when to investigate? If a patient is having an asymptomatic cyst and it's less than 1 centimeter in size, there is no need to investigate, but the patient has to be kept in a follow-up. But if the patient is symptomatic or it is more than 1 centimeter, then we have to do the investigations. So these include a number of investigations, routine blood biochemistry, as well as the HbA1c is very important in these patients because these patients have shown that there is a deterioration in the either control of the glycemic index or a recent onset diabetes in the last 1 year. Coming to the cross-sectional imaging, so it is usually done for the characterization of the cyst. Both the gadolinium enhanced MRI with MRCP and a pancreatic protocol has been recommended by the various groups. However, the accuracy to diagnose a pancreatic cyst is much more in MRI with or MRCP compared to the other CT scan. This is because the contrast resolution of the MRI is higher compared to the CT scan. However, we must remember that the accuracy remains low even if we have combined the multiple modalities. The accuracy again remains low to identify the specific type of PCN, that is pancreatic cystic neoplasm, differentiating the small PCNs from non-neoplastic, non-epithelial cyst or connection to the ductal system. So whenever we do a cross-section imaging study, the reporting must include the cyst morphology and location, cyst size, communication with the pancreatic duct, whether high-risk stigmata is present or not, the growth on the follow-up scans, and the multiplicity of the cyst. Coming to the IPMN, there is the cystic dilatation of the involved segment which is caused by the mucin. The important thing is in the main duct IPMN, there is segmental or diffuse dilatation of the main pancreatic duct which is more than 5 millimeter in size. Dilatation is more homogeneous with a regular margin. There is no ductal obstruction and nodules are present either in the duct or in the cyst. And there's grape-like secondary ductal dilatation. So that has to be differentiated sometime with chronic pancreatitis, where the ductal dilatations are there with strictures, stone formation, or the side branches ectasias with non-cystic appearance. Coming to the mucinous neoplasm, so these are usually the round cystic masses with sharp margins and having high signal intensity on the T1 weighted images due to the mucins. Signs of malignancy in MR is usually a papillary vegetations, nodules or septa. If the wall thickness is more than 3 millimeter, size of the cyst is more than 7 centimeter, the number of loculations are more than 4, there is hyperintensity content, and there is compression or infiltration of the adjacent vessels or organ. If more than 3 radiological features are there, then we can accurately diagnose that the patient is having malignancy in about 91% of the cases. Coming to Spain, it is a rare tumor, but we very often encounter these tumors in our practice. So it is present in 1 to 2% of all the exocrine pancreatic tumors. The CT scan shows a well-capsulated heterogeneous mass with both solid and cystic component, often showing peripheral enhancement and varying degree of internal hemorrhage. In MRI, we find there is well-defined rounded mass, heterogeneous signal intensity in both T1 and T2 weighted films due to the necrosis and hemorrhage. The solid components are usually peripherally located, well vascularized and enhanced later than the pancreatic parenchyma. Now, intraductal tubular papillary neoplasm is defined by Yamaguchi et al. So it's defined as the pancreatic intraductal neoplasm, tubular papillary growth of neoplastic cell, and there is no mucin production. In pathology, it is a solid tumor and obstruction to the dilated duct. There is no mucin. The growth is usually tubular papillary. There is uniform high-grade atypia throughout the neoplasm. And there is a ductal differentiation which is being supported by the cytokeratin 7 positivity or with the positivity of cytokeratin 19. They are necrotic foci with no acinar differentiation. In radiology, we find the two important signs, that are the two-tone sign and the cork of wine bottle sign. In the cork of wine bottle sign, you can see in the image C that the tumor is surrounded by a fluid in the dilated duct, and the growth is recognized there. There is also abrupt disruption of the main pancreatic duct by the non-visualized tumor and the dilated MPD and dilated branch ducts. Coming to the EUS, so it is a complementary modality and not to be done at the early stage. So if there are enough evidences that you can diagnose cystic neoplasm and the patient needs surgery, so this may not be added to your armamentarium and you can go straight away unless the patient had an history of acute pancreatitis. So it should define the morphology, it can be used for the cytology and also for the biochemistry. Contrast harmonic enhanced EUS gives a better resolution, but again it should not be used at an early stage. So it can give a better resolution for identifying the nodules, to identify the vascularity of the nodules and to see the septas. So in case of the contrast that is used is the micro bubbles. So these are of the size of around 10 microns in size, and that are introduced intravenously, and that can be picked up. EUS FNA is done as a resort to whenever we find something which is known as a worrisome features. So this can also be used to analyze the CA, cytology, amylase, and the mutational analysis. So again, the endoscopic ultrasound should be done only when there are some doubt in the cross-sectional imaging and when we cannot basically reach into the diagnosis that whether we have to do surgery or not. If it is there that we need to do surgery, so go ahead and do with the CT and the this MR. So these are some of the findings in endoscopic ultrasound. In pseudocyst, there is a cyst with features of pancreatitis, but there is no septations or mural nodules. In MCN, there is cyst with septations of various thickness and visible wall thickening, and there is peripheral calcification. In main duct IPMN, there is ductal dilatation of 5 centimeter or more with intraductal nodules, but there is no obstruction. However, there is atrophy of the pancreas. In branch duct IPMN, the cyst is usually communicating with the main pancreatic duct. The MPD is less than 6 millimeter. There is multiple cyst and atrophy of the pancreas. The other investigations which I would like to go is the but important one is the pancreatoscopy that has been excellently shown yesterday in a video session by Professor Rao. So which can go into the location and extent of the main duct IPMN, that is help to differentiate between the chronic pancreatitis and main duct IPMN also. Intraductal ultrasound is also less available, but it's also very useful to diagnose main duct IPMN. Circulating epithelial cells. So this is a paper which is published by the German 2 to 3 years back, where we can see that in around 35% of the patients which shows the circulating cells, and that can be picked up. However, this does not have any correlation with the variety of the cyst that is having. PET is again one of the modalities that is increasingly used. FAPI PET is more commonly used nowadays, and this is a paper which is published by the German again. So FAPI is a fibroblast activation protein inhibitors, and as there is the mesenchymal transformation from the epithelioid cells, so these are being increasingly picked up and taken. So it is very helpful in differentiating between the low-grade IPMN compared to the high-grade or invasive carcinomas. So in short, the pancreatic cystic neoplasm, we should first look into the clinical features, go into the radiology and biochemistry. If required, then only we should poke into the EUS and FNA. And we can do some of the fancy investigations that are already there. And after all, there is the risk assessment followed by the stratification of the patient, which can be done as a high-risk stigmata or a worrisome features. Thank you very much.